let us discuss the definition that what a risk-reducing surgery exactly is. So a risk-reducing surgery or prophylactic surgery is a form of surgery whose purpose is to minimize or prevent the risk of developing cancer in an organ or a gland that has yet to develop cancer and is known to be at high risk of the same. It involves removal of normal glands at risk in patients with high-risk pathogenic mutations. Now let us discuss the importance of these risk-reducing surgeries, that why we need to do them. So for general malignancies, it helps in prevention of cancer development. There's reduction in the cancer risk. A few studies have shown improved survival rates, mostly after mastectomy and all. A prophylactic mastectomy, improved survival rates have been reported in few studies. Also enhanced quality of life in terms of psychological issues, because when a person gets to know that they have high risk of cancer, they have a lot of psychological fears, and after this risk reducing surgery, that can be improved. Coming to opportunity for early detection and intervention, because there is a chance of detection of occult cancers after risk reducing surgery. Then family planning and fertility preservation are options that are provided before we take a person for risk reducing surgery. So after they've completed their family or fertility preservation issues have been discussed, then only we select a woman for risk reducing surgeries. Also, it gives us oncologists as an opportunity for integrated approach to cancer prevention. Now, let us study how we identify these high-risk individuals. So, depending on the history, a personal or a family history of cancer, depending on the ethnicity and ancestry, personal history of precursor lesions, like if in the past a woman had endometrial hyperplasia, so in the future we know she'll be at high risk of having endometrial carcinomas. If there's history of unexplained infertility and multiple miscarriages. So of note is over here that women with these high-risk features should be referred to a multidisciplinary board and then accordingly referred to the genetic counseling center. Now let us see, like once a woman is diagnosed of being at high risk to have a particular cancer, so what risk reducing strategies we can basically offer to them. So first of all, our lifestyle modifications, then surveillance, active surveillance is a key, risk reducing medications or chemo prevention, and then finally the topic for today, risk reducing surgeries. Okay. Now let us come to the indications of these risk reducing surgeries. So when there is a lack of effective screening, like we know for ovarian cancer, an effective screening method is still not very validated till now. The UK CTOC statement, which was recently had been published, said that the screening for asymptomatic women with no family history of the ovarian cancer would not be effective in saving lives. So this was for normal women. The benefit of surgery outweighs the risk of the disease. Then we should offer these risk reducing procedures. And also when these procedures minimize cancer risk in patients with high risk genes. So before I move into the further details, let me just briefly tell what are these high risk genes. So high-risk genes are generally high penetrance genes, which basically lead to a lifetime risk of cancer of more than 5% in an individual. And the moderate penetrance gene will lead to a risk of cancer in 2 to 5% of the cases. So all the guidelines have recommended that especially for high penetrance genes, where the lifetime risk of cancer is more than 5%, a genetic testing and a further risk reducing surgery should be considered. Now, what are the types of risk reducing surgeries which we are offering? So, we have divided this into two. One is the hereditary breast ovarian cancer carriers and for the Lynch syndrome carriers. So, these are relevant for all gynae-oncologists. So, coming to the hereditary breast ovarian cancer carriers, the surgeries which are offered are for breast, it is risk reducing bilateral mastectomy. Also, a contralateral prophylactic mastectomy can be offered. And these two procedures can be done with or without reconstruction of the breast. Coming to the ovarian surgeries, we have wrist-reducing bilateral salpingio-oophorectomy, wrist-reducing early salpingectomy with delayed oophorectomy, and we have wrist-reducing hysterectomy with bilateral salpingio-oophorectomy. Coming to our Lynch syndrome carriers, so we offer mostly wrist-reducing hysterectomy with bilateral salpingio-oophorectomy to these women. So before we go into the details of each of these surgeries, let us first discuss the unique challenges of these risk-reducing surgeries. Because before taking up these patients for any form of procedure, we have to inform them, we have to counsel them, and that is very important because these interventions are irreversible. So the risk versus benefit analysis should be done prior to surgery. There are ethical issues as normal organs are being removed. Psychological issues as women will further going to lose her fertility once we remove her ovaries. Even when we are going to remove the breast of a patient for considering for bilateral risk reducing mastectomy, so there will be a lot of psychological and identity issues for the woman. Coming to surgical complications, because these are less acceptable in women where normal organs are being removed. Also, there's a need for meticulous histopathological examination. And finally, the economic impact. So a recent review of literature which was performed showed a high decision uncertainty associated with the uptake rates of risk reducing interventions. So all these we should keep in our mind. Now let us dive into the details of these risk reducing surgeries, when and where we are going to do them. So first, just a brief note on risk reducing surgeries in breast cancer. So these charts have been made from directly NCCN and ESMO guidelines. So first, again, when a patient comes to us, or a woman for that matter, normal relative also of a patient will come to us, we have to identify the high-risk population. So again, the high-risk genes for breast cancer are the BRCA1, BRCA2, the PLB2, then we have the ETN gene, we have the TP53 and CDH1. Also, a compelling family history is very important for breast cancer patients, and history of thoracic radiation therapy before the age of 30 years. There are other basically moderate risk penetrance gene also responsible for BRCA for breast cancer patients, but again we have to individualize them accordingly on the basis of their family history. Now coming to the risk reducing options which are available. So for screening, we have enhanced surveillance, that is we can use now MRI also, and mammography is basically preferred to be done after 40 years of age, and this can be done at 6 monthly intervals or 5 years younger than the youngest family member with breast cancer. Now coming to risk reducing medications, so we can provide selective estrogen receptor modulators such as tamoxifen or raloxifene or aromatase inhibitors. Then we can offer a risk reducing surgery. So the risk reducing surgery is risk reducing bilateral mastectomy. And when can we do this? So the age exactly is not specified. In a few guidelines, it has been mentioned that we can offer them at 25 to 30 years, because the screening is also to be started by the age of 25 years. But again, the age of mastectomy has to be individualized according to the risk factors for the person, that is the family history and what genes are affected. Now, the BRCA carriers who come with an ovarian malignancy, what can we do for them? So, risk-reducing mastectomy over here is not validated within 5 years of an ovarian cancer diagnosis due to a high rate of ovarian cancer relapse in these cases. So, once these patients are free or are have no disease for at least 5 years, so then only we can offer these risk-reducing mastectomy surgeries to them. Coming to the outcomes of bilateral risk-reducing mastectomy. So, in studies, it has been seen that it reduces the risk of breast cancer by 90%. The role of contralateral mastectomy should be offered as a choice to patients with the BRCA mutations. And the alternative of this is we can also advise them prophylactic breast irradiation, because over here there might be a psychological benefit that the breast tissue is not being removed. Special considerations. Nowadays, a nipple-sparing mastectomy is a reasonable alternative to total mastectomy, and also immediate reconstruction is safe and should be offered to all women. So these were our guidelines and recommendations for the breast cancer patients. for a risk-reducing mastectomy surgery or high risk for breast carcinoma. Now let us discuss the role of risk-reducing surgeries in ovarian cancers. So before we go into the details of these surgeries, we should know about hereditary ovarian cancer. So as we can see from this figure that a lot of genes for breast, ovarian and endometrial cancer have an overlap. Hereditary ovarian cancer is associated with 20 to 25% of ovarian cancers with mostly mutations in the BRCA1 and BRCA2 genes. They mostly have an autosomal pattern, dominant pattern of inheritance, with the BRCA1 mutations having a significant lifetime risk of ovarian cancer of 39 to 46%. For the BRCA2 mutations, the lifetime risk is 11 to 27%. Also, genes which are associated with Lynch syndrome and mutations in genes such as RAD51C, RAD51D, and others involved in DNA repair pathways are associated with the hereditary ovarian cancers. So over here, we'll mostly focus on the hereditary breast ovarian cancer, that is HBOC. So in this second column, we can see this is the lifetime risk of tubo-ovarian cancers. So for the BRCA1, which we have already discussed, is 40 to 60%, BRCA2. Then the IP1, the risk is 5 to 10%. For the PLB2, it's 3 to 5%. So risk-reducing surgery is offered in them in special cases. Then we have RAD51C and RAD51D. Now let us come to the criteria for genetic testing for ovarian cancer. So now when we have actually selected the patients who are high risk for development of ovarian cancer, so when to subject them for genetic testing? So first of all, we have the personal history criteria. That is, if a woman is having epithelial ovarian cancer or had a primary peritoneal or fallopian tube carcinoma. Coming to her family history, if one or more first degree relatives were affected, if multiple second degree relatives were affected, and if bilateral or multiple primary cancers were present. Specific genetic syndromes we've already discussed. And coming to our ethical considerations, like in Ashkenazi Jewish descent. The ESMO has recommended individuals with significant family history should be offered genetic testing using multi-gene panels of clinically validated HBOC genes, and clinicians should be aware that a family history-based testing misses about half of these cases, and strategies to identify these high-risk individuals are to be developed. So this was an update of the ESMO guidelines, which was published in March 2023, and the NICE 2024 guidelines, that's why I have recommended these two extra high-risk criteria, and that is person who have been identified through a cascade of testing. That is, if a few relatives have been tested, and then from there we find a high-risk basically individual from the testing of various relatives. The other criteria over here is person with non-epithelial ovarian cancer if no previous mainstream genetic testing was done. So these patients, along with other high-risk women, should be discussed in the multidisciplinary tumor board, and then accordingly a decision should be taken whether or not a genetic testing or further risk-reducing measures should be taken for them or not. So over here only in these meetings and discussions, we have to individualize the patients who have a more than equal to 5% lifetime risk of developing a cancer. So a very important aspect for these individuals is the post-genetic counseling. So one, they have been tested and we know that they are high risk of developing ovarian cancer. So a very important part is that we have to counsel them. And this discussion should be based on medical and psychological implications for not only the individual but her family as well. The risk management should be individualized, and when available, validated tools should be used to aid in the decision making. Risk management should be carried out in specialized high-risk clinics that are multidisciplinary and include psychologists where possible. Also, enhancing awareness and availability of testing in at-risk relatives should be a priority. So, what surgery we are going to offer them? As we've read before, so we are going to offer them a risk-reducing salpingo oophorectomy. For the BRCA1 patients at 35 to 40 years, we can offer the surgery, and for the BRCA2 patients at 40 to 45 years. And an important thing we have to keep in mind is that the family should be completed. So the ESMO recommendation, so once a patient or a woman is a carrier for BRCA1 or 2 pathological variant, so we should offer them screening. But the recommendation over here is poor because 6 monthly the transvaginal ultrasound and serum CA125 level can be measured from the age where RRBSO is recommended. Also, following RRBSO, we should remember that no intensified gynecological screening would be required. And over here, we have to highlight that no intensified gynecological screening will be required, but screening will be required. Coming to the risk reduction, RRBSO between the ages of 40 to 45 years is recommended. Now, we'll discuss what is the risk-reducing salpingo-oophorectomy protocol. So, as we know, and we are doing it also in our clinical practice, we can either do it laparoscopically or as an open surgery. Most common is the laparoscopic approach, but when there's a contraindication to laparoscopy, like a general anesthesia cannot be given or previous abdominal surgeries are there, so an open surgery, according to the surgeon's discretion, can be done. Coming to the extent of surgery, so besides removing the ovaries and fallopian tubes, the surgeon may also inspect the pelvic and abdominal cavity for any signs of diseases or abnormalities. Coming to our surgical considerations, since the ovaries are small and discrete organs, they are relatively easy to be removed completely. But an important point over here is that the transection of the ovarian vessels on each side of the pelvis should be done at least 2 cm proximal to the ovary. And this is done so that no ovarian remnants are left behind. The procedure involves opening of the pelvic side wall peritoneum. We can visualize the ureter and the isolation of the infundibular pelvic ligament. Pelvic cytological washings are recommended for these cases. So the most crucial part of this risk-reducing salpingo-oophorectomy is the pathological assessment. So pathological detection is dependent on thoroughness of the tissue examination, and recommended protocols are also there which maximize tumor detection and emphasize the role of thinly slicing the tubes and ovaries and finally embedding the entire specimen for microscopic examination. Consequence of surgical menopause when it is being done in premenopausal women, and decreases a risk of breast cancer as well. Coming to our limitations, so the cost of the surgery, potential operative morbidity and mortality, and also surgical menopause in premenopausal patients who elect not to take the hormone replacement therapy. So these are the basically outcomes of RRSO. So various studies have reported that the risk of ovarian cancer the reduction in risk of ovarian cancer has been seen to be more than 96%. And also literature has reported that breast cancer risk decreases by approximately 72% in the BRCA2 mutations and 39 in BRCA1 mutations. So these basically data I've taken from various meta-analysis where they had shown that a significant risk reduction is there. But a lot of studies have also reported that the risk reduction is not very significant. Coming to the prevalence of occult cancers, that is found in 2 to 10% of the cases, and more often it is localized to the distal fallopian tubes. So once we have decided to take a woman for RRSO, she might opt out of it. She might say that I don't want to undergo a surgical procedure. So what alternatives we can offer to her? So the combined oral contraceptive pill is a strong protective factor for ovarian cancer in general population and has been demonstrated to substantially reduce the risk of ovarian cancer in the genetic pathological variants in the BRCA1 and 2. So a combined oral contraceptive pills is the alternative or chemopreventive measure for ovarian cancer. Now let us discuss the hormone replacement therapy post-risk reducing surgery. So as most of these procedures will be done in the premenopausal woman, we don't want to basically let her suffer the menopausal symptoms. So what we can do? So the NICE 2024 guidelines have offered hormone replacement therapy until the average age of menopause for people who have not had a breast cancer and who have had risk-reducing bilateral salpingo-oophorectomy before the average age of menopause. We have to take the opinion of a breast cancer care team as well, and we have to offer HRT accordingly. That is, who have had a breast cancer and who have had risk-reducing bilateral salpingo-oophorectomy. Because if a patient already is suffering from breast cancer and had received treatment of it, so we should also basically ask our breast care team whether it was ERPR positive, HER2 positive, and accordingly our options of HRT might differ. Now, when offering hormone replacement therapy to people who meet the criteria in the recommendations, what can we offer? So we have to use a combined hormone replacement therapy for people who have a uterus, use estrogen-only HRT for people who do not have a uterus. Start HRT as soon as clinically appropriate after surgery. We can consider insertion of a levonorgestrel intrauterine system at time of surgery. Discuss the individual risk and benefits for the use of HRT and offer vaginal estrogen to people with genital urinary symptoms associated with menopause who had not had a breast cancer earlier. Now, coming to again basically a review of literature which was done to see whether this HRT is safe or not. So it was seen in a lot of studies that short-term use of HRT following a RRSO does not increase the risk of developing breast cancer or negates the protective effect of RRSO in the BRCA1 or 2 mutation carriers with a personal history of breast cancer as well. So we can discuss with our breast care team and then go ahead with HRT. So these are the various preparations which are available. Now, let us see that what is the role of prophylactic hysterectomy in patients undergoing RRSO. Since she's already going surgery, so if she's going to benefit from a prophylactic hysterectomy, then accordingly we can counsel the woman for the same. A recent review had found that the BRCA mutations were identified in 4.3% of women with endometrial carcinoma. Association between the BRCA pathogenic variants and the development of serous uterine cancer has been established in a few studies, primarily with the BRCA1. Any absolute risk, though, remains low, and it is not clear if the potential magnitude of this benefit associated with hysterectomy is sufficient to justify the risk associated with the procedure or not. Also, it has been recommended that a potential role of reducing hysterectomy is present in patients with a genetic predisposition or having a carrier mutation of the PLB2 variants. Prophylactic hysterectomy as a possible risk-reducing surgery needs to be discussed during the counseling sessions with the woman herself and accordingly a decision taken. Also, we should remember that hysterectomy should not be routinely recommended to reduce the cancer risk unless other indications are there. So if a woman comes to us with basically pathogenic variants in the MLH1, MSH2 or MSH6 genes, then she'll be at also a risk of endometrial carcinoma. So we can consider a prophylactic hysterectomy for her. When there's a benign uterine pathology, maybe she has a uterine fibroid and she wants to get her uterus removed, then we can actually consider for prophylactic hysterectomy along with the RRSO procedure. So let us see what the benefits of this procedure. So once the uterus is removed, the woman can be offered estrogen alone HRT, which is associated with decreased risk of breast cancer and also eliminates small risk of uterine cancer if tamoxifen is used. Coming to the risks, so again we have the surgical risk, that is injuries to the anatomical structures like urinary bladder, ureter, intestines, rectum, anus. There's risk of sexual dysfunction. Vaginal cuff dehiscence can be seen in a few cases. UTI and urinary incontinence, wound infection, pelvic abscess are all the risk of any surgical procedure. Now let us come to the role of prophylactic salpingectomy with delayed oophorectomy. So the timing of RRSO is not universally established. However, there's an agreement that it should not be performed before the age of 35 or before completing childbearing. So, delaying this type of intervention until physiological menopause should be considered, should be taken into account for the selected cases, like if a woman is high risk of cardiovascular events, when there is bone mass density loss, and other side effects of early menopause are already present in a woman, then a delayed oophorectomy can be considered. Okay, so now let us come to the various ongoing trials for risk-reducing salpingectomy with delayed oophorectomy as an alternative to RSO. So just to keep in our minds that at present, delayed oophorectomy is not recommended by any of the guidelines, and it has been suggested that to do this procedure only under clinical trial setting, because the evidence is still less of risk-reducing salpingectomy with delayed oophorectomy and its benefits. So these are the three trials which are being conducted at present for risk-reducing salpingectomy with delayed oophorectomy. So these are the Protector trial, we have the SOROC trial, and we have the TUBA-VIS-2 trial. All these trials are prospective and preferential studies with numerous centers and countries which are participating in them. The arms for Protector trial, SOROC and TUBA-VIS, the first two arms are similar. So the risk-reducing salpingectomy over here is being compared with a risk-reducing salpingectomy with delayed oophorectomy, and this is being done in all the three trials. But for the Protector trial, we have another arm, that is the no surgery arm or the screening arm. Coming to the inclusion criteria, so again we are going to compare the three. So the first inclusion criteria for the Protector trial is the BRCA12, RAD51CD, BIRP1, or a PLB2 pathogenic variant carrier strong family history. This is similar to the TUBA-VIS-2 trials. And for the SOROC trial, only the BRCA1 pathogenic variant carrier is included. For the Protector and again TUBA-VIS-2 trial, the premenopausal women are taken into account. But for the SOROC, also menopausal women will be included in the study. Coming to the criteria for presence of at least one fallopian tube, it is similar for the three groups. Age more than 30 years is to be included in Protector trial. For the SOROC, the age is 35 to 50 years. And for the TUBA-VIS, they've divided the age for the various pathogenic variants. For the BRCA1 pathogenic variant, it is 25 to 40 years. For the BRCA2, it is 25 to 45 years. And for RAD51CD and BRIP1, it is 25 to 50 years. Also to be kept in mind over here is that completion of childbearing should be done for all the three trials. And in SOROC, they had actually mentioned through natural conception. So later on, amendment was done to the SOROC inclusion criteria, where individuals who are receiving hormonal therapy from Pendennis therapy will be included. Individuals with a history of any prior cancer and who have completed chemotherapy at least 30 days ago will be included in the study, and also individuals who are considering assisted reproductive technologies will be included. So let us study now what are the primary outcomes of the three trials. So for the Protector trial, sexual functioning is the primary outcome. For the SOROC, time to development of incident high-grade serous carcinoma, specifically ovarian, primary peritoneal or fallopian tube cancers. And for the TUBA-VIS-2, we have the cumulative incidence of the ovarian cancer at target age 46 years and 51 years for the BRCA2. So the expected results and study completion for Protector trial is in 2027 with a sample size of 1,000. For the SOROC, it is in 2037 with a sample size of 2,262, and for the TUBA-VIS, it is in 2040 with a sample size of 4,000. So this was about the various surgeries which are being offered for ovarian cancer risk reduction. Now let us come to the role of risk-reducing surgeries in the endometrial cancer. So over here, we know that Lynch syndrome represents the highest group with a 40 to 60% lifetime risk of endometrial cancer. And nowadays, we are using the reflex immunohistochemistry for the mismatch repair genes on endometrial cancer. And this prompts the identification of the affected individuals. So once we know that these individuals are affected with high penetrant genes, a benefit they can achieve from surveillance for colorectal malignancies as well. And also, the affected female relatives should be offered a risk-reducing hysterectomy from the age of 40 years. Now, let us discuss what is the lifetime risk with Lynch syndrome of having an endometrial cancer or an ovarian cancer. So, depending on the pathogenic variant, when MLH1 is mutated, the risk of endometrial cancer is 34 to 54% at an average age of 49 years. For the ovarian cancer, it is 4 to 20% with an average age of 46 years. Coming to the MSH2 and the EPCAM pathogenic variants, at 21 to the risk of endometrial cancer is 21 to 57% at an age of 47 to 48 years. Also, ovarian cancer risk is around 8 to 38%. With the MSH6, the risk of endometrial cancer is 16 to 49% at an age of 53 to 55 years. So over here, the average is slightly later. For the PMS2, 13 to 26% endometrial cancer risk has been seen, which is slightly less at an average age of 49 to 50 years. And for ovarian, it is 1.3 to 3%. So now, once we know that an individual is high risk for Lynch syndrome, so a lot of criteria has been advised for the risk assessment for it. So I'm not going to go in the details of it because it more focuses on the colorectal cancers. So the recent were Amsterdam criteria 2 and the revised Bethesda guidelines, and this has been recommended by the ESMO clinical practice guidelines, the risk assessment for Lynch syndrome. Now let us just see the Lynch syndrome survey recommendations which are important for us. So if a woman and for ovaries, a CA125 and transvaginal ultrasound can be done at yearly intervals at the age of 30 to 35 years. So now let us study the various recommendations for risk reduction in Lynch syndrome. So depending on the pathogenic variants, the recommendations are made. So I've taken over here the opportunity to basically discuss the risk reduction recommendations for ovarian cancer as well. So coming to the MLH1 and MSH2 or the EPCAM pathogenic variants, so surveillance is definitely recommended. We have to consider various risk-reducing agents, and hysterectomy as a risk-reducing option should be considered, and the timing is based on the patient factors. That is when she completes her family and her family history. All this should be considered. For the ovarian carcinoma, again, an ultrasound CA125 can be considered at clinician's discretion. Various risk-reducing agents can be considered, and the option for a BSO has to be individualized. For the MSH6 also, we have similar recommendations. But for the ovarian cancer, where MSH6 is mutated, since the risk of the having ovarian cancer is really less, so there's insufficient evidence for specific recommendations regarding a risk-reducing surgery. For the PMS2 also, PMS2 carriers appear to be at only a modestly increased risk of endometrial cancer. So hysterectomy over here as an option can be considered, and timing can be based on patient's factors. And for ovarian carcinoma, again, we have insufficient evidence, and as such, a risk-reducing surgery is not recommended. Screening can be done according to the clinician's discretion, but again, it is not very beneficial for PMS2 variants. Now, as per NCCN, so the prophylactic hysterectomy or risk-reducing hysterectomy is recommended by the age of 40 to 45 years or earlier based on the family history. So over here, risk-reducing hysterectomy refers to removal of the healthy uterus to reduce a person's risk of developing cancer. And over here, to be kept in mind is that we are removing the cervix as well. So research on hysterectomy in high-risk women has shown that hysterectomy is an effective way to lower the risk of endometrial cancer, and also that hysterectomy over here will not increase the woman's survival. So now coming to our surgical considerations of risk-reducing hysterectomy. So a very important thing is over here that a consultation before the procedure has to be done, and counseling is very important of the patient. Then considering performing a pre-operative endometrial biopsy, because sometimes an occult carcinoma can be detected in these endometrial biopsies as well. So if cancer is detected pre-operatively only, again we can go ahead and perform a staging surgery. But if the biopsy is not performed somehow before the procedure, the uterus should be opened intraoperatively and examined carefully. The approach for a risk-reducing hysterectomy can be vaginal, laparoscopically, that is MI surgeries. We can do a laparotomy depending on the patient's choices, physician's discretion. And sometimes patients with high risk of Lynch syndrome may or may not be offered a colectomy. Colectomy as a risk-reducing procedure is not offered most of the times because it drastically changes the quality of life of a person. So screening is recommended for these women, but if a person is very high risk of developing a colorectal cancer, then it can be considered, and you have to take the surgical oncologist, your team also into account. Now, before I move on how we are going to follow up these risk-reducing surgeries, just a small note on these special situations, that is Lynch-like syndrome and the BRCA. So both these syndromes are mimicking the basically proper disease. Like Lynch syndrome, we have deficiency in the MMR or MSI, but it excludes the MLH1 hypermethylation. So it is resembling the Lynch syndrome due to this deficiency mimicking. But it is not increasing the risk for having maybe endometrial cancer as such. So for these women, we should not basically advise a risk-reducing surgery. And similarly, with BRCA, which is a defect of homologous recombination repair mimicking the BRCA1 or BRCA2 losses. So in this also, a risk-reducing surgery has not been recommended till now. But these two syndromes we should be aware of so that we are not subjecting the woman to unnecessary surgeries and unnecessary surveillance. Now let us come to the follow-up after these risk-reducing surgeries. So prophylactic surgeries or strategies succeed, but they do not completely eliminate the risk of developing hereditary neoplasms. So the role of follow-up is not negligible. And this should be explained to the woman before taking up her for risk-reducing surgery. So the follow-up will include annual pelvic ultrasound examinations for RRSO patients, a serum CA125 testing. Cervical cancer screening should be continued in the case uterus conservation was done. A bone density testing and careful consideration of the postmenopausal symptoms are required, and hormone therapy for menopausal symptoms. Now let us come to the various ethical considerations. So the safety of a risk-reducing surgery has yet to be proven. So it is still an experimental surgery. To restrict women to fertility treatment with significant side effects because of still unproven surgery is questionable. Because over here, we have to remember we are removing the normal organs of the woman. After RRSO, IVF or ICSI are no longer possible. A social freezing could be an alternative option for this group, and women could harvest and freeze their oocytes or an embryo prior to risk-reducing surgery and use them afterwards or as well. However, these has its own disadvantages because there are additional costs, there are lower odds of conceiving, and the complex psychological and social impact of social freezing on patients has also been seen. So finally, to summarize, depending on the pathogenic variant, the procedure and age, for us, BRCA1 pathogenic variants can be offered bilateral salpingo-oophorectomy, but no earlier than 35 years. For the BRCA2, bilateral salpingo-oophorectomy again can be offered, but no earlier than 40 years. Also, for various pathogenic variants like RAD51C, RAD51D, BIRB1 or PLD2 pathogenic variants with a total lifetime risk of ovarian cancer of 5% or over, a bilateral salpingo-oophorectomy procedure is recommended no earlier than 45 years. And for the MLH1, MSH2 or MSH6 pathogenic variants, hysterectomy with bilateral salpingo-oophorectomy no earlier than 35 years is recommended. So this is a summary of all the guidelines and all the risk-reducing procedures which are relevant in gynae oncology. Lastly, I would just like to say that an ounce of prevention is more than a worth of pound of cure. So accordingly, keeping all the guidelines in our mind and keeping all the recommendations, we should counsel our patients and meticulously choose these patients for a risk-reducing procedure. Thank you.
Thank you, Dr. Begha. It's a nice presentation. You have covered almost the whole story of genetic counseling, genetic testing, as well as risk-reducing various surgeries, as it is there as of today, and the present guidelines also. So now we have among us Dr. Shruti Bhatia and Dr. Shiva Singhal to discuss about this presentation. But before the starting anything, I should emphasize one thing, that because there is no other way of preventing the growing, are very fast growing number of ovarian cancers which are seen in our population at a very young age. There is no way to prevent this ovarian cancer, unlike the other cancers like cervical cancer is there. So the only option, there is, though it's a small part, but the only option is to go for genetic counseling, genetic testing at those patients who are having the disease at early age. So only way to prevent this ovarian cancer in a small group of population, of course, is do the genetic counseling, genetic testing, and should have, and all the majority of the cancer centers, there should be genetic counseling unit, genetic testing unit, which is mandatory. It has to be established. Otherwise, discussing the risk-reducing surgeries is of no use. Though you can prevent a smaller amount of people, but there should be a good nurse and the genetic counselor as there, because you do not know who are the people at risk, and you have to identify. It is not a very easy procedure to identify among the population, among the relatives of those who are having the disease. So there is a genetic counselor is there, genetic counselor nurse is there, the NGO, sometimes the NGOs give the support, and also the psychologist, which is mandatory, because you need to do certain procedures which the people will, with the patient, will not be able to accept in our population. But because in the Western population, people are already very well versed about the situation, and always they are going to the literature and the discussion which is occurring in the hospital. There are various leaflets, pamphlets are there through which they can know. But in India, if you think about in India, there is no such things, and most of the people are not aware of this thing. So genetic counseling is mandatory. And one thing we should encourage the genetic testing, especially BRCA and BRCA1, BRCA2, and some other panels which are very relevant of ovarian and endometrial cancers. So now with this small discussion, I would request Dr. Seema Singhal and Dr. Shruti Bhatia to comment on this particular topic.
Sir, thank you so much for this comprehensive overview. Dr. Shruti, there are some questions in the chat box. Can you please take up those questions?
Yeah, first of all, good morning and excellent presentation, Megha. Few questions are there, and which is important. One is, what is the alternative to RRSO?
Ma'am, we can give this medical measures, like we can give a mild oral contraceptive pills, and if they are not willing, then active surveillance can be done. But then we should also inform the woman before taking active surveillance that we might miss also, because again, it is not very effective right now, ovarian cancer screening. So she will have to go a transvaginal ultrasound, say 125 every 6 monthly, and if she is not willing for that also, then
one more question here. How you said that, oh my god, खत्म हो गया क्या? ये उड़ गया मेरा, I think. Oh. Class में नहीं हो?
Yeah. I'll add one more thing here, like OC pills is a very good option. Another option which is being discussed in literature is GnRH analogs,
yes,
which are again can be given to these patients, but again these have a lot of side effects.
yes.
So they have a limited role and not used that commonly. And we all know tamoxifen can be used for prevention for breast cancer, but the best is, I think, OC pills, as you have said. Another question is how to identify BRCA or Lynch similar syndromes.
Ma'am, again we'll have to see the details of the basically genetic test which we are doing. So like, just a second. Like for BRCA, we know that a homologous recombination defect will be there, which will mimic the BRCA1 or 2 loss. So again, for that we have to do a proper genetic testing for them. For Lynch-like syndrome also, ma'am, there is the MMR deficiency will be there, but again, we have to exclude over here the MLH1 hypermethylation. So again, this will be by genetic tests only, which will be able to differentiate the BRCA and the Lynch-like syndrome.
So as I think Dr. Ranjit Mandal has also said, genetic testing is actually a very important part of cancer management, and especially when there is a family history. So good counseling of the patient, the relatives, and genetic testing is important. I'll add just few points here. I mean, you have done an excellent presentation. There is something like we all know that the risk-reducing surgeries decrease the risk of ovarian cancer in a big way. They also decrease the overall mortality, but we have to keep in mind the risk reduction in primary peritoneal cancer is not that significant.
It's not significant, yes.
Yeah, and so we have to keep the patients under surveillance. So you have clearly mentioned that they have to be followed up by ultrasound CA125, because whatever we do, we cannot reduce. We are reducing and we are not totally nullifying the cancer risk. And peritoneal cancer risk always remains. So this they have to be monitored. And another thing I'd like to point out, something for endometrial cancers is a minor variant is the Cowden syndrome. Again, that is a very minor proportion of our endometrial cancer cases, but these cases are also there. And these are also benefited by risk-reducing surgeries as we do in Lynch syndrome. Hysterectomy does offer them good protection. So after the age of 35, 40 years, and when she has completed her family, we can offer them risk-reducing hysterectomy in these cases. And one more point, yes, you have also mentioned though briefly about the tubal intraepithelial cancer. So can you tell me, if we detect tubal intraepithelial cancer in this patient who has been done, we have done a RRSO, we have studied the CFIM protocol and detected stick, how do we proceed further?
Then we can keep her in close follow-up, because we can actually advise her according to the risks, because she has a high risk of developing ovarian cancer in the future. But for tubal intraepithelial carcinoma, we can, ma'am, once we've removed the bilateral tubes, we can keep her in close follow-up. But again, we have to tell her the risks of having increased high-grade serous ovarian carcinoma in the future. So once, if she's completed her family well and good, we can go ahead with the prophylactic further surgeries. But ma'am, complete risk we will not be able to eliminate for her.
No, yeah. So those patients who have stick, they have a higher chances of getting a peritoneal cancer later on.
Yes,
so ideally, if patient has completed a family, we should do a staging, and then we should do a hysterectomy and complete staging in these cases, and also tell her most probably she'll not require any further treatment, and but she has to stay under follow-up because she has a higher chances of peritoneal cancer later on.
Absolutely, Dr. Shruti.
One question from my side.
Yeah.
I would like to know what is your interpretation regarding the UK CFOX trial, which was in this context?
Yes.
Ma'am, in the trial, actually for the normal population, it has been seen that the ovarian cancer screening is not very effective. But for high-risk patients, like for the BRCA positive variants and all, so the screening will be effective for them at least. We'll be able to detect the malignancy a little earlier. The mortality has seemed to be a little reduced in the latest statement. But for normal general population, we should not. It is not beneficial.
It was a phase 2 trial. UK CFOX trial was a phase 2 trial. It did not compare the two populations. Actually, it was done only in that population, which had an increased risk of familial cancers, right?
Yes, ma'am. Yes, ma'am.
So it is so then when you are interpreting a trial,
yes,
just just concentrate into that. Fine. Any other questions, Dr. Shruti?
I don't think so. Yeah. No other questions in the chat box.
The chat box also there is no question. So Megha has presented the topic so nicely and covered so